Dr. Kim.
Thank you for that warm welcome, Elizabeth, and thank you for everyone for joining tonight in this very cold weather. And I chose this topic of speaking in regards to acid reflux, also known as GERD, because it's actually one of the most prevalent GI diseases in the United States. And as the flyer said, about 15 to 20% of Americans suffer from this, and a reason to see a gastroenterologist. It's actually one of the number one reasons that we actually perform an endoscopy. And so we're going to talk about recognizing it, managing it, and when not to see a gastroenterologist. And I'm going to touch upon questions that patients have asked me in the office. And mainly it's about medications, as most patients don't want to be on medications and when or when not to take them. So, and I'm going to begin. Oh. So what is GERD? And it is gastroesophageal reflux disease, again, affecting about 15 to 20 millions of Americans. It is really the backflow of the acid that normally belongs in the stomach, which backflows into the esophagus. And this is a term that you will frequently hear me say during this meeting is the lower esophageal sphincter opening. This is when it is not working properly, and a lot of patients suffer from acid reflux due to this malfunction. So again, acid reflux is a backflow called acid reflux, which irritates the lining of the esophagus, leading to uncomfortable symptoms such as heartburn or regurgitation. Okay. And again, when patients come to see me in the office, I like to explain to them that the esophagus, the lining of the esophagus and the lining of the stomach are completely different. So the function of the esophagus is just really very simple. It is to let the food pass into your stomach, and it doesn't have that protective lining that the stomach does to protect it from the stomach acids. So when things go wrong, it's when that lower, and when you see the abbreviation of LES, it's the lower esophageal sphincter. That gateway is when it's weakened and relaxes inappropriately, and that's when all the acid starts to come up. And the main take-home message from this slide is, why do people get acid reflux? And why does your neighbor next to you can eat everything and not have the symptoms that you're suffering from? And so some of the common causes, unfortunately, is a anatomical reason called a hiatal hernia, which we can diagnose through an endoscopy. You can have a hernia anywhere in your body. You can have a belly button hernia. You can have an inguinal hernia. And you can also have a hernia where your esophagus and stomach meet, and this is loosening of the muscle wall, so which again lets the acid come up to the esophagus. Unfortunately, in America, obesity is probably one of the more common reasons why patients suffer from acid reflux. It increases the abdominal pressure, relaxing or weakening that lower esophageal sphincter. Pregnancy for the same reason, certain medications and dietary choices can all weaken that lower esophageal sphincter and worsen your reflux. And we can go over some of those dietary choices as well. So in the office, there's two types of patients that also come to see me. Very typical symptoms of acid reflux and heartburn, that burning sensation in your chest after you eat, or the regurgitation, where you actually feel the back of your throat or mouth with the food backing up. But there are also atypical symptoms, and these patients are usually referred to me from either their cardiologist or their pulmonologist, where they don't experience the typical symptoms of that burning sensation, but they're coming to me with symptoms of cough or voice hoarseness. And to them, they were shocked that they were even told that they may have acid reflux. And this is when the acid reflux has backed up so much that it can irritate their vocal cords or even their lungs to cause that coughness. So there's, like I said, there's two types of patients that usually come to see me, really typical symptoms of acid reflux or those atypical symptoms that I briefly mentioned. And usually those are referrals from other specialists. And why is it important to address acid reflux? Well, as benign as acid reflux may seem, it can cause damage to your esophagus over many years if untreated. And unfortunately, if that damage occurs, it's usually permanent, something called Barrett's esophagus, which I will explain in just a second. And it may increase your risk for something called esophageal cancer. So as benign as acid reflux may be, it may cause serious complications of something called esophageal cancer. So what happens is, as I alluded to before, the lining of your esophagus and the lining of your stomach are not the same. So when the esophagus continues to get irritation and inflammation from the repeated acid exposure, what does your body do? Your body tries to adapt to these changes and not in a good way. So the esophagus starts, and an easy way for me to explain this to patients is that the esophagus starts to change and change to mimic the lining of the stomach. So one organ shouldn't look like another organ. And when that starts to happen, bizarre cells can start to come up, and these are what we call precancerous cells, and again, something called Barrett's esophagus. But once you have these changes are permanent and cannot be undone. So these patients are now followed with us lifelong and on lifelong medications to reduce the risk of serious complications such as esophageal cancer. So this is why patients with ongoing acid reflux should seek seeing a gastroenterologist. So foods and habits that trigger heartburn. So if we talk about diet, this is very unique and specific to the patient. I myself have acid reflux, but if you look in these high risk foods, chocolate, peppermint, citrus fruits don't bother me. But I know that tomato-based products such as pizza or, spaghetti may trigger my heartburn. So everyone is different in what foods may trigger their acid reflux. So when patients ask about diet, which is the most common question I get in the office, because really most patients don't want to be on medications, it's really tailored to that person and what foods will trigger them. So what may trigger my heartburn may not trigger yours. And you don't want to eliminate all these foods because honestly, we live to eat. We enjoy eating, and taking away all these foods is not realistic. And also with coffee, caffeinated drinks, alcohol, carbonated beverages, what I tell patients is, yes, if you're drinking 10 cups of coffee, I'm going to ask you reduce it to one or two. There are patients that are able to cut off coffee completely, but some people are not. So I ask just to reduce your intake. If you're drinking one or two cans of soda, I'm going to ask you to try to reduce that. It's all about quality of life as well. And then meal patterns. So we'll go into a little bit more too. But really, they've done studies on this, and this is probably what patients will notice the most improvement on is not eating within 2 or 3 hours of going to bed. So if you're eating at 7, we ask that you not lay back until 10 o'clock. And why that is just gravity. So if you're eating and triggering your stomach to produce those gastric juices, and then you're laying flat, gravity is no longer pulling the gastric juices down, and it's all coming back up to your esophagus. So this is probably one of out of all the dietary eliminations and the meal patterns, this is where patients notice the most improvement. Obviously, easier said than done, especially with our work schedule, our life schedule. Like today, I'm sure many of you joining me today, rushing throughout work, unable to eat, and having that large meal when they come home, and then going straight to bed. And unfortunately, like I said, it's easier said than done, but it's something that, like I said, out of all the meal patterns, the high risk food and the beverages, most patients notice the biggest difference with the 2-3 hour bedtime window period. So again, these are just lifestyle changes that most people understand and know. Again, easier said than done, but this is what has helped um, um, most patients avoid taking medications or even taking medications as needed. And we'll talk about that with the next slides with medications. Eating smaller frequent meals, but really, like I said, waiting that 2 or 3 hour window period and elevating your bed with 2 or 3 pillows. They even sell GERD pillows too, but and they're pretty popular. And I have patients who have this, have great success, but just propping your head with 2 or 3 pillows will help as well. Okay, so let's talk about medications because this is really important. This is something that most patients in my office don't want to do. Most patients say, Doc, I don't really take medications. I am not a big medication person. What in the diet can I change? Should I be concerned that I may have Barrett's esophagus or I have damage to my esophagus? So these are the most common questions that I get. And I tell patients who come to see me, I tell them, and I'm sorry, I wasn't able to incorporate this into my slide, but I usually show this iceberg picture where there's a water line and the tip of the iceberg and the majority of the iceberg under the water line. And underneath that water line, majority of patients do not seek the help of a gastroenterologist because most of the medications that are on this slide are over the counter. Patients treat themselves. And if they go away, you're not going to come and see me. The patients that are coming to see me is patients that are needing to take medications 2 or 3 times a week, patients who are taking medications and unable to get off of them, or taking over-the-counter medications and it didn't work. These are the patients that are coming to see me, and that is the tip of the iceberg. So there are 3 types of medications, and I call them tiers of medications. Antacids, Tums, Rolaids work really quick, but just as quick as they work, they wear off. So these are the medications that give you that quick relief, but you'll notice that you're going to need to take a lot more of these because they're not meant to be to last throughout the day. The next best medication is called Pepcid, and that you can buy over the counter. It usually lasts half the day, so some people may need to take it twice a day. It's much stronger than Tums or Rolaids, but as we go up these tiers, there are more side effects. And the best medication is something called Prilosec, Nexium, Prevacid, and these are called proton pump inhibitors. And what has come into light, mainly through the media and through research, is that they may have more side effects, and we're going to talk about that as well. And this is this is a conversation that I have with my patients time and time again, because there is a side effect called dementia, and most patients come and say, I read about this medication and I don't want to get dementia. My grandmother had dementia, my mother had dementia, or other certain side effects. Like I said, we'll touch upon in just a second. But again, Prilosec, Nexium, Prevacid, these are 24-hour release medications, and these work the best. Okay, so I'm just going, and I should have tweaked the slide just a little bit. There are many proton pump inhibitors, but the go-to medication, let me see if okay, Mouse is working. So the go-to medication is Prilosec, and we call it omeprazole. So when you come to see your primary care physician, or you come to see me or any gastroenterologist, and you agree to start a medication where it's indicated, this is the go-to medication. And the efficacy we put as 1. There are many patients who come to see me where omeprazole, again, which is Prilosec, may not work. And I may need to switch you to something called Nexium, or I may need to switch you to something called Acifex. And you can see, even though they are in the same family as what we call a proton pump inhibitor, and how you recognize these medications, the azole, that's how they all end. They're on the same umbrella. Not every medication works the same. So when patients say Nexium works better for me, well, it's actually true. It has a higher relative potency. So, and then the lower one is Prevacid, and another one, this is mainly, we give this in the hospital. It's called Protonix, pantoprazole. That is the only PPI that we give in the hospital usually, and this has the less potency. But usually the side effect umbrella is the same. So the best medication, like I said, is the proton pump inhibitors. But why are patients concerned about taking these medications? So most of my, with obviously with the internet, with ChatGPT, everyone does their own research. So before I prescribe a medication, I have to also tell them there's certain side effects, because they're going to get this medication and they're going to say, well, actually, doc, I didn't take it. I read all the side effect profile and I decided not to take it at all. So the most concerns that people have and have asked me in the office is the risk for dementia, the risk for osteoporosis, and the risk for kidney injury, or an infection called C. diff. Now, there are some clinical associations with this, but I will let you know that the study that they had for dementia were patients between the ages of 75 to 85. And as you know, as you grow older, your risk for dementia may increase. So what we got, the guidelines that we go by are the American College of Gastroenterology. And yes, they say that more research is needed, that there is a possible association, or, but we need more data on this. So a direct causal link has not been definitively established. And if you need to use this medication, we need to use this medication. We'll go into that as well. So the take-home message is, what I want to tell patients is that side effects don't always happen, just like Tylenol. So the way I like to explain it is, Tylenol can cause liver failure if you look at the side effects. If you take Tylenol, you may not get liver failure. Most people don't. And taking a PPI, you may not get dementia. You may not get osteoporosis. Most patients don't have side effects. And also, we don't want you on these medications for a long time. At a certain point in time, if we feel that you are better, we're going to taper you off these medications and put you on demand. And we'll talk about that in a little bit. So when to see a doctor this is actually important. When you're taking over-the-counter medications more than twice a week, if the medications that you're taking is not working, if you're having difficulty swallowing, you're having chest pain that they deemed is not cardiac related, if you're losing weight, obviously you're going to come and see us, and to recognize your symptoms early, to modify your lifestyle. But like I said, if we start you on medications, the idea is to get you better while in tandem working on your lifestyle, modifying your lifestyle, and taking these medications as needed. Because anyone with acid reflux knows, yes, it will get better, but unfortunately it will come back. So once we get you off the medications, we advise the patients to take the medications as needed. And so over the counter, again, taking antacids, Pepcid, lifestyle changes, and so this is when to see a gastroenterologist, when you have frequent symptoms, when over-the-counter medications don't work, and to even confirm whether or not you have heartburn through that endoscopy, and to assess if you have esophageal damage, such as the Barrett's esophagus that we spoke about earlier during this presentation, and obviously if you have difficulty swallowing or weight loss. This is a QR code for you to access these slides. I didn't make a slide on this one, but another question I get in the office is homeopathic regimens. This is hit or miss. This will be really based on the individual. Some people take licorice, some people do aloe vera juice. Some people take ginger supplements. This will depend on the patient and how severe your acid reflux is, but I am not against taking this in conjunction with changing your dietary habits or your lifestyle. This is the end of my slides, but I'm here. I'm more than happy to answer any questions or concerns with my audience.
Thank you, Dr. Kim. We do have questions. The first is, I have frequent heartburn. I'm going for an endoscopy on Friday. What will the gastroenterologist be looking for?
And that's a great question. I want you to understand that most endoscopies come back normal, okay? And this is good. It does not mean that you may not have acid reflux. It means that you have no damage from the symptoms that you're having. So we like to label this NERD, non-erosive reflux disease. So this upcoming endoscopy after your procedure, the most common conversation that your gastroenterologist will have with you is that everything is normal. And patients come back, well, does that mean I don't have acid reflux? And I say, no, it means that you don't have any damage. And that's what we don't want to see, those long-term side effects that I said were irreversible. Another conversation that your doctor may have is that you may have that hiatal hernia that I alluded to earlier too, that you have changes in the anatomy that lower the threshold of your sphincter where it's not working normally, and that's why you're having this frequent acid reflux. Those patients with a hiatal hernia, we don't recommend surgery on the get-go. If medications and dietary modifications work, we advise against surgery. And the third scenario, which may happen, is that you may have an ulcer. You may have really severe acid reflux where now it's eating away at the lining of your esophagus, where you will need to take that PPI, omeprazole, pantoprazole, on a longer basis to heal that ulcer. And we call that erosive gastritis. So those are some of the common scenarios that I see after my endoscopy, but most of the time, most endoscopies come back normal.
Okay, and can you have an endoscopy and a colonoscopy at one time?
Yes, you can. So the misnomer is that, is it too much anesthesia? And no, it's not. So as big of this production of getting you this endoscopy is, it's more about the anesthesia. So the endoscopy itself is only about, believe it or not, 5 to 10 minutes. The colonoscopy also individual based, but it's about 20 to 30 minutes. And if we do both at the same time, it would be maybe about 30 minutes. And so in this crazy world where everyone's very busy, we would prefer not to bring you back 2 times, in 2 different days, right? 2 different rides. But it's not any more anesthesia. But I also want to disclose on that is that not everybody needs an endoscopy. Okay. If you're not having any heartburn symptoms or any of the symptoms that I discussed, then you're not going to need it. But yes, at the end, yes, you can do both at the same time.
Okay, and can anxiety cause acid reflux?
Yes. So good old anxiety. Let's talk about this one. So I will say majority of stress and anxiety does cause a lot of my patients their symptoms. But this is the catch, and this is where you have to be careful. Even in a young patient, older patients were worried about cancer or anything more serious, but you don't always want to blame stress or anxiety. And I explain that to my patients in the office as well. Anxiety and stress, we blame that when nothing comes back. When you've had an endoscopy or you've had an ultrasound and all your and the PPI is working, you feel better. And they're like, Dr. Kim, why did I have this heartburn? I didn't have any changes of diet or weight gain and yes, then I will blame it on stress or anxiety, but that's after all the testing has been completed.
Okay, and this individual is wondering if they should try Pepcid before starting a PPI. Yes, Tums never worked for them.
Right. So yeah, I would absolutely agree with starting Pepcid. So remember, I alluded to the different tiers. So if you're popping 3 or 4 Tums a day, it's time to move on. You're going to go to that Pepcid, which I said would last half the day. So you made it need to take it morning and night. And if that doesn't work, then you can start the Prilosec or Nexium. Yes.
Okay, and what about getting acid reflux if you haven't eaten anything? Is it possible? Is
Yes,
that
yes, because
okay?
you skipped a diet. And I think, speaking to majority of my patients, it's that lifestyle I was talking to you about. We're running around, forgetting to eat. And, a lot of patients come and say sometimes it is elicited, but when they skip their meal.
Okay, and just to remind people, if you do have questions, you can put it in the Q&A portal, at the bottom of your Zoom screen. Um, is it possible to have acid reflux without symptoms? Like you go to a doctor and they see damage from reflux, but you've never
Yeah.
had symptoms?
Yes, and that is what we call silent reflux. Bizarre, right? How can your reflux and be silent? So I can get, and that's a very good question as well. So in the sense that I there's two different scenarios I want to mention right here. So I said that there's typical symptoms of acid reflux, that burning sensation, the regurgitation. But remember, there were atypical symptoms. So patients coming to me with cough or voice hoarseness, and they're like, I'm being referred to you by my ear, nose, throat doctor. I'm being referred to you by my pulmonologist because I was coughing and they're telling me this is my acid reflux. These patients actually tell me they don't have that burning sensation. They don't have that typical symptoms, but they're presenting atypically. Another scenario that I said that sometimes we see, and sometimes we see this in the hospital, people come in for a bleeding ulcer, that they have symptoms of bleeding. And when we do that endoscopy, we find the ulcer, but they're like, I've never had any heartburn. I've never had any pain. Where did this come from? And this is called silent reflux. And these patients are a little bit harder to treat because they don't manifest until they have a complication of the acid reflux.
Thank you very much. It looks like I think we've gone through all of our questions. Thank you so much, Dr. Kim, for your informative presentation this evening. At this time, I'd like to remind everyone at home to take a few minutes to fill out the survey using the link